Good afternoon, everyone, my dear friends. Welcome to the DCI platform for the virtual learning 31st January 2021 Sunday. Before starting the presentation, I would like to read out the instructions for the attendees. Please listen carefully. At the time of registration, complete details must be furnished since same will be captured for generating certificate or CDE points. No request for any change, modifications in their details shall be considered. An e-certificate of attendance will be emailed to all attendees on their registered email ID. CDE points will be awarded to the dentists registered with state dental councils or tribunals of India. Certificates will be sent to the attendees by email within 3 days of conclusion of each webinar who have attended the entire session of webinar uninterruptedly. Please check your junk mail folder just in case the certificate email got delivered there instead of your inbox. Just in case any attendees did not receive the certificate, please visit www.dciindia.gov.in and search for webinar option. There you can download the certificate. Feedback link will be sent to your registered mail along with certificate. And I am really happy to announce the highest attendance in the last webinar. The first being the Sabita Dental College and Hospital, Chennai, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Yogita Dental College and Hospital, Cade, and Jananayak Devi Lal Dental College, Sirsa, Thai Mugambika Dental College and Hospital, Chennai. I congratulate them wholeheartedly. Thank you for attending the webinar. We hope that you are all benefited with the previous webinar. Coming to the today's webinar topic, that is electronic working length determination, clinical tips and troubleshooting by our eminent speaker, Dr. Ajay Logani, sir. As you all know, Dr. Ajay Logani is one of the renowned clinician and academician who has done extensive work in endodontics. He is now currently serving as professor in Department of Conservative Dentistry, Endodontics, All India Institute of Medical Sciences, Center for Dental Education and Research. And he did Masters in Conservative Endodontics in 2000 from MGR Medical University, Chennai. Then principal investigator for many projects funded by Department of Biotechnology, Ministry of Science and Technology, Indian Council of Medical Research, World Health Organization, and All India Institute of Medical Sciences. And trust in many research fields, that is including dental trauma, regenerative endodontics, and forensic odontology. Dr. Ajay is also the member of Indian Association of Conservative Dentistry and Endodontics, ISDE, and Indian Endodontic Society, Indian Society of Dental Research, and currently the president of Indian Society of Dental Traumatology. Before handing over to Dr. Ajay, one of the Einstein quotes reminds me, your desire for success should be greater than your fear of failure. Dear friends, many of you watching this webinar, please understand that this is one of the greatest opportunities given by Dental Council of India on a free platform. All the practitioners, undergraduates and postgraduates, please make use of the eminent speaker who has spared his valuable time. Once again, thank you very much all the friends for joining on the Sunday afternoon. To Dr. Ajay.
Yes, thank you very much, sir. Now it's my duty to introduce the moderator of the day, and that happens to be Dr. P. Karunakar. Everybody knows him, but it is my duty that again I would brief you about his profile. He has been the former president of the IACDE. He has been a member of the Dental Council of India, and currently he is the principal professor and head of the department of Panineeya Dental College. He's also the Senate member and the chairman for the PG Board of Studies at the KNR University of Health Sciences, Hyderabad. Sir has been working very actively, and he has more than 54 national and international publications to his credit. Thank you very much, sir, for introducing me. And we would start today's webinar. It's 4:05. We are looking at to be on time at 5 p.m. And the topic which I have taken, before that, I would like to put on record the gratitude to the Dental Council of India, all the president as well as the members of the Dental Council of India to come up with an idea like the continuing dental education program. This is the 22nd webinar today, and I'm sure everybody has been benefiting with those webinars. And special thank to my dear friend Virendra Goyal, who's been coordinating it for the past 2 or 3 days, and the Deputy Secretary of the Dental Council, Mukesh Kumar, also, who's been with us for the past 48 hours and trying to get this thing to work. This topic is electronic working length determination and clinical tips and troubleshooting. The reason why I chose this topic is because I personally thought that when I gave this topic almost 6 months back, that we would be needing to speak on this. I thought that this would be a topic which would help the general practitioners as well as the postgraduate and undergraduate should get sensitized to this method of a working length determination, and hence the reason for taking up this topic. Hopefully, over the next 50 minutes, I would do justice to this topic, and you would get some information and insight on electronic working length determination. 5 years back, if I had to travel from one place to the other, I actually did not know how much time it's going to take or which route to take, and I had to plan at least 20-25 minutes in advance, seeing the traffic in at New Delhi, and that is what it used to be. Even after planning, sometimes we used to end up reaching late by 20 minutes because we really did not know which was the best route, which was the least congested route to take. But in the last couple of years, maybe a decade, things have changed. Now we have the Google map. You feed your destination from one place to the other, and it tells you the best route. Not only it tells you the best route, it tells you how much time you're going to take. So frankly, you reach on time, your accuracy has improved, and all these things are only possible with the advancements in all these spheres of life which we have been seeing. Similarly, in endodontics, whoever has the final years, the interns, the postgraduates, and the faculties do realize that in endodontics also, we have to measure this distance. And this distance happens to be from the coronal reference point to the apex of the tooth. And we call this distance as working length. For the definition, the seminars are also meant to answer some of the questions which you would come across in Vivas. The American Association of Endodontists defines working length as the distance from a coronal reference point to the point at which canal preparation and obturation should terminate. Please mark every word. It's just almost like I'm just trying to say that every slide of mine in the next 50 minutes would have a message. So on this, it is the definition, but you have to see the definition also carefully. It says that it is the distance from a coronal reference point to a point at which canal preparation, that is biomechanical preparation, and your filling should terminate. So from the definition itself, you can understand that how important is working length for us. Now, when I say it is very important, obviously all steps of endodontics are important. That is the 3Ds, that is the access opening is very important. The biomechanical preparation is very important, and obturation is also important. But for me, if you're really looking at success, is the biomechanical preparation. And if you're really looking at getting your biomechanical preparation perfect, it is the working length preparation. It is not me who's saying that. We have a landmark journal article in 1990 which clearly said that what happens if your working length is off or on the spot. If you are 0 to 2 millimeters from the radiographic apex, you have a success of 94%. It comes down to 68% when you are more than 2 millimeters short. And at the same time, it is approximately 75 to 76% if you are right at the radiographic apex. So you can understand from this slide that it is in millimeters what we are talking about, that the success of root canal therapy would depend on these millimeters. Now, I cannot overemphasize this fact that how important is working length measurement. Again, as I said, every slide would have a reference. This is specifically for postgraduates. You need to know which are the landmark articles in our field. You need to learn from these articles that what exactly are they telling us. This particular one is a study by Jogren right back in 1990. Obviously, the emphasis is on the success or the iatrogenic errors also. Everybody who does endodontics would realize that the number one cause for a flare-up or an inter-appointment pain is an error in working length determination. So unnecessarily pain can also be caused in case you are not doing your working length proper. We do have a solution for this, and the solution is that you need to calculate your distance from the coronal reference point to the apical constriction, like what we were doing in the Google map for calculating from one place to the other. For working length, we have a traditional method, which is the radiographic method. For the last 60, 70, 80 years, we've been depending on this method of working length determination, and that's the radiographic method. The Ingalls method of radiographic working length determination which is taught to every postgraduate and which is given in every book. But you've got to understand that radiographs have an inherent limitation, and that limitation is that you're trying to represent a 3D object in a 2D representation. So that's one of the biggest limitations of a radiograph, that you're looking at. You can never see the third dimension on an intraoral periapical radiograph. This is the biggest limitation, but that's not the only limitation. You have many more limitations, and like the radiation hazards, you have the anatomic noise in the sense that the zygomatic arch could come over your maxillary teeth and you would never see the root end. Sometimes the canal may be buccally or palaty angulated, which you can again not see on an intraoral periapical radiograph. One of the biggest is the inter-observer. What I may see, my colleague may not see. As it says, is this picture or a rabbit or a duck? 50% would call it as a rabbit, 50% would call it as a duck, and that's what happens with intraoral periapical radiographs. You give two experienced endodontists a working length radiograph. One would say it is 1 millimeter short, the other may say it's 0.5 millimeter, and if you consult the third, he may say that it is perfect. So there are inherent drawbacks in a radiographic method of working length determination. Professor Stephen Buchanan, all the endodontists would know him. I had the opportunity because he came down to our institute for a lecture, and that was almost 10 years back, but we discussed with him on a lot of things, and one of them was working length. And this is a statement from him which is etched in my mind. And he went on to say, in his opinion, determining a working length on a radiograph was one of the worst concepts in endodontics. Sorry to be harsh on that, but I would agree with that. And a lot of my colleagues now would understand that we've also practiced endodontics in the 90s on radiographic working length, but we went sometimes horribly wrong. Retrospective hindsight, I would agree to this fact that radiographs may not be the best method of working length determination. Fortunately, we have a solution, guys. Sometimes in life you're stuck with radiographs is the only method of working length determination, and if you are not having the right solution with it, but we still have to depend on it. In endodontics, it's not the same. We do have a solution, and that is the electronic apex locators. Now, this is not something new. If you trace the history, goes back to the 30s. Sonada and his colleagues have gone on to get this concept way back in the 30s. But we, as researchers, it comes out slowly. We've started to get apex locators in India from the 90s, the late 90s. World globally, it's been there from the early 90s. So almost 60 years, this concept had been there. Why I emphasize this, because you must know the history. Students must know the history. Our colleagues who have done world over research, is because of that we are able to do perfect endodontics today. So we must acknowledge all those people who've done hard work. 60 years it took them to get them into the market and on a routine use is what the electronic apex locators history tells us. I have been personally, why I took this topic is because I've been using this apex locator since 99, and I am a very strong proponent of using apex locators. But whenever I try and talking to my colleagues, may they be endodontists, may they be of different specialities, may they be people of general dentistry or final year interns or students, they do not use this apex locators. It is like not an official survey, but kind of speaking to people. And whenever I am talking to people, if it is a room of say 50, there would be only 10 people using apex locators. And whenever, and the 40 would still, when I say still, I'm talking about last year to last year. So very recent. If I take a opinion poll of 50 people in general dentistry or in specialities, or even in my own specialties, 20 maybe now graduated to 30% of the people still use apex locators. And whenever I ask them this question, why are you not still using apex locators? The only answer they give me is that it is not accurate. It is not accurate, and that is what something which I get to hear again and again from a different specialty people, and a lot of dentists tell me this. This is what I understand. Most of the times the barrier for people is that they think apex locators are not accurate. We've got to understand, is that a myth or a reality? It could be. Like, I'll give you an example. The example is, there are certain clinics which says root canal is painless. Now, is that a reality or a myth? I tried doing some research on that. For me, that's a reality. You cannot say root canals are painless. Some amount of pain, maybe post-operative, during operative, is always associated. But is it the same myth or reality with apex locators? Is what something I have tried to understand. Is there a problem in the accuracy of apex locators? What the 30% of the people or the 70% who are not using it, and they quote that it is not accurate, is it a reality? Let us see. How do you come to know about reality? You can only come to know about reality by either experiencing it yourself or going on to the literature. For us, it is evidence-based endodontics. EBE is what we call it, evidence-based endodontics. We've got to go on to the evidence to say whether apex locators are accurate, yes or no. But if you see these articles, and there is that title on the top which says modern extracts locators are reliable for determining working length, And if you see the left bottom article, in 2000 it says it's more accurate than an RVG. Forget a analog IOP X-ray, compare it to a RVG X-ray, and they say apex locators is much, much more accurate. And the advantages are obvious, that it is going to get you less radiation. You don't have to take less retakes, and obviously it hastens your endodontic therapy. We've all been trying to highlight the use of rotary files for making our endodontics faster. If you try and take 3 X-rays during your endodontic therapy, that is a working length, a master cone, and an obturation, it takes 20 minutes extra. Add that to your single sitting is a point which I must highlight, that for me, using apex locators is not only radiation less, it is faster endodontics also. So the literature tells us that apex locators are not exactly unreliable. They are actually reliable, as we would keep seeing in the coming slides. Let me make some myths which are to be cleared. These are all myths which are from people. So the 30% people who said it is not accurate, they said we found that apex locators were not accurate when we were trying to do working length measurement in a pulp necrosis case. When some of them said no, when I was trying to do it in a vital tooth irreversible pulpitis case, the apex locators were not accurate. Get this message very clear, guys, that apex locators are not affected by the pulp status, and it's my personal experience, and that's what the literature tells us, that there is no difference as far as the pulp status is concerned on the accuracy of apex locator. Neither does the status of the periapical region also makes any difference to the accuracy of apex locator. So with a periapical lesion or without a periapical lesion, a small periapical lesion or a large periapical lesion, nothing affects the accuracy of the apex locator. So these are the two main things which the people said, that guys, whenever I have a non-vital versus a vital or a periapical or a root resorption, I get wrong readings. And the literature tells otherwise. My understanding is also that these do not make a difference to the functioning of an apex locator. So obviously the million-dollar question is, what makes a difference on the accuracy of apex locator? Now that's it. There is only one person or one thing which makes a difference to the accuracy or not accuracy working length by an apex locator, and that's us. That's the operator. So frankly, apex locators are affected by the way we use it. It's dependent on us, how accurate are your apex locators or otherwise. That's the topic which I said maybe should benefit for all the people. So it's twofold benefit. For the people who have doubt that apex locators are not accurate, and that is why they're not using. And for those people whom I can convince to start using apex locators in general dental practice, that is the BDS, that is the final years, the interns, or the other specialty people whom I can convince that start using apex locators, this clinical tips may improve the accuracy. When I say may, I would reframe, would increase the accuracy. I would not say increase. Make sure that their apex locators are accurate. Henceforth, just be very, very cautious on the slides, the material on the slides, the message on the slides, which I would provide, because as I told you in the beginning, every slide would have some message for you to take across back to your office. Tip one, how to get your apex locators to the best. Choose the right one. Choose the right one. You see, we have many generations of apex locators, first, second, third, fourth, fifth, sixth. I've had the advantage, or maybe whatever you may say, of having used all generations of apex locators from the first to the sixth. The first, the second had disadvantages. The third generation apex locators are the ones which are ratio-based apex locators. After the third generation apex locators, please, this is my personal opinion, but get it very clearly, fourth, fifth, sixth generation apex locators function almost similarly as the third generation apex locators. There is very minimal difference as far as the physics behind apex locators is concerned from the third generation. I would not short of saying that they are marketing gimmicks of the fourth, fifth, and sixth. For us, the gold standard, which changed the accuracy of apex locators, was the third generation apex locators. So the message is very clear that if somebody tries selling you a sixth generation apex locator and say this is better than the fourth or the fifth or the third, it's almost a marketing gimmick. It's the third generation apex locator where the physics changed everywhere, where the microchips came in, where the ratio-based apex locators came in, which have shown us to be very, very highly accurate. So you must also know this, that when somebody, when a marketing guy is trying to sell you an apex locator, you must only concentrate on that whether it is, obviously the first and the second are not available. The third, fourth, fifth, sixth are almost similar. For me, the third generation apex locators, which is shown as a company product here, is the one which I swear by, actually. Would not recommend, but for my personal, I swear by the third generation apex locator. As I said, Karunakar sir asked me in a mock question saying that people may ask you what is impedance. My answer was already ready, that I would not be able to answer the physics behind apex locators, and it is an extremely complicated thing. But the only thing which I can help you is two things. Just keep it in mind that the apex locators only function when a circuit is completed. The circuit is completed with the lip clip around the cheek. When you insert the file, when it comes in contact with the PDEL from the apical foramen, the circuit is completed and the apex locator starts to function. Simplest way of putting it, how apex locators function. You want to go down deep into the physics of apex locator. Guys, for postgraduates, only one article in the last 30 years, Nikofor's article in the International Endodontic Journal, volume 39, 2006, which I have shown you in this slide, is the only article which tells us about the physics behind apex locators. No book, DCNA does have some material on the functioning of apex locators, physics of apex locators, but if you are really looking at understanding the physics behind apex locators, guys, just this article, no other article till date in literature which can give you the best information. I've already told you this slide. Third generation is the gold standard. I am not having any kind of commercial interest. I do not, but I have to tell you that there is no better apex locator than this one. This is the old version. They have the newer versions, but this is gold standard. If you are, it's not me. You go on to see any laboratory study published. It is mandatory to compare it against this particular apex locator. So it is the gold standard. Why is it gold standard? Because it says that you can go up to 96%, 97% accuracy. So 100 cases, maybe you're really looking at 4, 5, 6, 7 only going wrong. And that is also operator dependent, is my experience with this apex locator. I hope I'm getting my message right. This is the gold standard. It has an extremely high accuracy. Tip 2. So the tip 1 was choose the right one. Tip 2, you have to understand that it is an electronic device. It is an electronic device. When you buy a new gadget, may it be a phone or a television, what do you do first? Read the manual. You've got to read the manual. The manual of an apex locator tells us many things, right from how to start from it and how to make it function, how to maintain it, how to do it on a patient, and what to do when it does not work. So like any electronic gadget, you've got to read the manual. You're not supposed to throw this manual. Nowadays, the Apex locators are coming with a soft copy. They have a CD. You just have to load it. And you've got to get the salient features out of those manuals, stick it around in your clinic when you know how to do it. Because for learners specifically, you may miss a step, but you must read the manual before you start your use of Apex locators. Pre-check function. Guys, this is very important. This is something which I've learned over years. This is something which rarely affects the accuracy of Apex locators. You may think that a low battery with two or a one strand in your battery, can it affect the Apex locator accuracy? Yes. It has been documented. It is written in the manual loud and clear that if your batteries are not charged properly, the accuracy of Apex locators is affected. So again, it is operator dependent. Don't blame your Apex locator if it is showing you a wrong reading. Some of the Apex locators tell you to pre-calibrate your Apex locators. As I would show you, every Apex locator has a different way of calibration. Some of them are supplied with a chip, which you are supposed to fix it there, calibrate it at least once a month, as per as the manual. Some of them say just connect the lip clip and the file holder. You would know whether the circuit is functional. So small things before you start functioning. Check your battery, calibrate the Apex locators. Even third generation Apex locators, fourth ones require some amount of calibration in a month or so for a continuous use of showing the accuracy of Apex locators. Once you've done this, chosen the right one, chosen the right one, you've read the manual, you've pre-checked the function, follow these small steps. These are extremely small steps, which you may already be doing it, but sometimes you may not be doing it or missing it. It really has an impact on the accuracy of Apex locators, is what I want to emphasize. My tip for that: follow these small steps. Ideal access opening. Ideal access opening is not only for prevention of instrument fracture or a straight line access, it is for a good electronic working length determination. I cannot overemphasize on an ideal access opening. With ideal access opening, pre-flaring. So the yellow mark which you see are the shelves. You are supposed to remove these shelves and then get a straight line access. An article tells us, our experience tells us, that whenever electronic working that is done after pre-flaring, the file is able to reach the apex less hindered there, and the accuracy of apex locators go high. So my two small steps were: have an ideal access opening, straight line access before you do your working length determination. Please pre-flare your canals. A crown down technique, in a smaller way to say it, a crown down technique, pre-flare, maybe an orifice shaper, maybe a gate splitter, but pre-flare your canals if you're really getting that 100%, 97, 98, 99% accuracy with your apex locators. Adequate isolation. I have seen my kids doing working length in a flood. The saliva is flowing all over, and they're trying to do an working length. You see, as I said, that the basis of apex locators is complete the circuit. If you have saliva flowing in and around, it may come in contact with your file holder, may come in contact with your file, and complete the circuit before, and you would show a wrong error. I do understand, be practical. I cannot recommend rubber dam for all patients, but at least a cotton roll and a suction is necessary when you are doing it. So something is an ideal case, there could be a practical solution. Rubber dam is ideal, but the cotton rolls become a practical solution with a low vac or a high vac suction. The message here is that you cannot do an accurate electronic working length determination if you have liquids or salivas flowing there. You have to isolate your tooth. If you have a distal caries exposure or a mesial caries exposure, you have to do a pre-endo buildup. May it be with an intermediate restorative material. You don't need to do it permanently. But as you can see it in the first photograph, there is bleeding from there. There is gingival clavicular fluid flowing from there. And what does it do? It flows it right into the pulp chamber, comes in contact with the file, completes the circuit, and then you realize the apex locator is wrong. Where was the apex locator wrong? We were not doing the right things. So if you do have a caries exposure from the mesial or distal or a grossly broken down tooth, it is mandatory. Again, these are few things which I cannot overemphasize. Mandatory is what I use is to do a pre-endo buildup. You may need to have a whole tooth buildup by a composite before you can take up for an electronic working length determination. Simplified, just build up the walls, may it be temporary, for the electronic working length determination. For radiographs as well as for electronic working length, tip number 4 is that you require a stable reference point. Now, these are some photographs which I have taken during my own teaching to my own postgraduates. The only thing which I emphasize here is a stable reference point and how to get to look at your stopper. You always have to look at the stopper from the side. Place your mirror on the side and an indirect vision. The second photograph emphasizes that if I'm looking on a direct vision, it seems that the stopper is resting on a solid reference point. But at the same time, when I change the angle and see it from the side view, the rubber stopper is almost 2 millimeters away. And if I measure this as a working length, and when I end up doing this as my working length, I may over instrument and may over obturate and cause pain to the patient. Again, not the fault of the apex locator, fault of us, fault of the operator. So a stable reference point on which your rubber stopper can firmly be sitting. Make sure from the side view that the rubber stopper is there. It's not tilted. It is flattened, flat on a solid reference point is tip number 4. Tip number 5, adequate moisture. You will know in the troubleshooting slide that apex locators do not work in extremely wet canals. They do not work in extremely dry canals. I told you the saliva, if it is flowing or if you have a solution overflowing, the circuit gets completed, it would not show. Dry canals, also working length with electronic apex locators is not possible. So you would ask me, it's a pertinent question. Again, my learning is from my postgraduate. So they ask me, what is sufficient moisture in a canal? So it should not be overflowing. Your pulp chamber should not have any liquid. Irrigate your canal with normal saline. Suck back and just put a paper point in the canal. Leave it for 5 seconds. Whatever moisture remains after the paper point has sucked the excessive moisture for 5 seconds is, in my opinion, sufficient. So message here is that should not be overflowing, should not be dry. You have to irrigate your canal with the normal saline or distilled water. Suck the excessive with the paper point, leaving it for 5 seconds. Whatever moisture remains in the canal, in my opinion, is sufficient. Practical way, tested way. So I think you can follow what I tell you as far as the right amount of moisture, what is required for working length determination in the molar teeth. Yes. Tip number 6, we have these apex locators which are the AFA. The AFA stands for all fluid allowed. They are the 6th generation apex locators. I told you they are gimmicks that people tell us that you can use it in all fluids. You can use it with sodium hypochlorite. Guys, don't do it. Even the 6th generation apex locator, as I told you, I have had the humble opportunity of working with all apex locators. You try using EDTA hypochlorite in your canal and try doing it even within AFA. You would have sometimes a wrong reading. Maybe sometimes you get it all because they claim they have it, but my experience says that you would get a wrong reading if you have this. So avoid it. You don't need to have any of these irrigants in your canal. You've got to suck them out, wash it with your distilled water or normal saline, and just get that 5-second rule of the paper point. You would have sufficient moisture. You would not go wrong when you would be doing the apex locator one. This is again something very important: file holder attachment and maintenance. Okay, a lot of times what we do is, in a haste, end up pinching the rubber stopper. Now, rubber is an insulator, and we don't hold the file on the shaft, so the current is not passing. The circuit is not getting completed. Be very careful. I will tell you in my next slide what to do, how to avoid this. Another thing is, sometimes our files have calcium hydroxide because we tend to apply with the same files an intracanal medicament. Those shafts sometimes may have the calcium hydroxide. Sometimes just by sterilizing the lip clips and the file holders, soot develops on it. You have to keep regularly cleaning your file holders with a gauze, or you can even use a sandpaper to remove all the debris which can accumulate. This message here is the circuit has to flow. So that is something, again, one of the points which I thought I should highlight. The other thing is that as far as a lot of questions sometimes say that the NIDA files versus stainless steel files, some people say they've had a problem using NITI files for apex locators. Guys, there is no difference. Whether you use a NITI file or a stainless steel file, as far as the conduction is concerned, stainless steel is better, but no doubt the NITI also has similar. It is sufficient for the apex locator to complete its circuit. So the type of file is not going to make a difference to the accuracy of apex locator, is something which is a tip from my side. This is what this slide should have come a little further before this. This is something: always have a sufficient length of shaft for you to attach your file holder. Say you're doing a 20 millimeter endodontic treatment for a molar with 20 millimeters, and if you're using a 21 millimeter file, you do not have any space with the stopper in place for putting your file holder. So if you have a 20 millimeter molar, you've got to use a 25 shaft file so that you have sufficient space for the rubber, for the stopper, as well as the file holder. So the message here is, always have a sufficient amount of shaft of file for getting the file holder in position without pinching the rubber stopper, or not having a proper contact is what we've noticed sometimes can get your working length wrong. This is important. This is important. This is something which my first year postgraduates do a mistake, and then they say the apex locators are not accurate. You've got to use a file which is snugly fitting up to the apex. So if you have a young molar, say a 16, 17-year-old boy, and you're trying to do it with a 10 number file, maybe the apex locator is not going to show it right. It's not. You have to have at least a 20 or a 25 in a distal canal if you're really looking at the accuracy of the apex locator to be there. And I would again highlight this procedure in the special considerations. So I would not speak to it out here. It is just that the file size does have an effect on the accuracy. It should fit passively, at least at the apex. It should not be super loose. You will not get a good, accurate working length. As far as the special considerations are concerned, I'll come back to this point in my in a couple of slides again. File size, and then this is again something which is not written in books. Again, something which I must overemphasize on you is, never attach the lip clip on the same side as you are doing the working length on, specifically if you don't have a rubber dam. So if you're doing it under cotton roll and a high vac, get the lip clip on the opposite side. We've seen many times that our hand movement gets the lip clip detached from the lip, and the circuit is not getting completed, and the apex locator does not move or shows an erroneous reading. Simple way out, always get the lip clip onto the opposite side of the face or the mouth on which you are doing the electronic working length difference. Small steps, I think I would recapitulate them. They were really small steps. I hope I got them drilled into your mind, but now we are ready to use the apex locators, and I will tell you how to use the apex locator. Okay, guys, always switch it on. Always switch it on. Make sure the circuit is completed and then start working length. So again, a question comes to which mark should we do it? Should we do it at 0.5? Should we do it the short? What the book tells us, what our experience tells us, what the manual tells us, what the articles tell us, that we've got to go up to the apex mark. The apex locators cannot read consistently the minor apical foramen. 97% when we say it is accurate for reading the apical foramen, the major apical foramen. I think I will repeat it. When we say we have an apex locator of 97-98% accuracy, we mean that it is reading the apical foramen. Now, depending on which type of apex locator you're using, it could be denoted by apex, it could be denoted by a 00 mark, it could be denoted by a red bar, it could be denoted by a continuous beep, it could be denoted by a figure saying over. Whenever you have to read your manual, but you've got to go on to that spot when you are doing your electronic working length measurement. Now, this is the article for the postgraduate which says that we cannot measure the minor apical foramen. It's the major apical foramen. That is why some of them have suggested that we must call it as the foramen locator. Apical foramen locator rather than the apex locator is a better terminology to be used. What do we do? Cutler tells us that we are not supposed to obturate up to the radiographic apex or the 00 mark. So what is recommended? Go up to the 00 mark, go up to the over mark, or where you have the continuous beep, measure that working length and minus 0.5 out of that. So simply put, when you have the first time, go in with the canal, go in with your file, reach the apex mark, take out your file, minus 0.5 from it, and again reintroduce it into it, and that is your minor apical foramen based on the Cutler's telling us that for younger patients it is 0.5, for the older patients it's approximately 0.8 to 1 millimeter short. This is something which I tell everybody. Apex locators don't depend on one reading. I will go a little fast because I need to finish it in the next 10 to 12 minutes. You have to take 3 readings. Don't depend on your first reading, specifically for beginners. Take reading 1, take out the file, put it back, again attach your apex locator, take it 2, second time, take it 3rd time. The average of the 2 or the best readings of the 2 or the most consistent readings which you've got in those 3 is supposed to be your electronic working length. Again, a tip, a practical tip which you must follow if you're really looking at accuracy. You've got to be cautious. This is something which we forget. Even the endodontist forgets that working length is dynamic. Archimedes told us we depend on a lot of physics that the shortest distance between 2 points is a straight line. No canals are straight. We straighten them. And once we straighten them, the working length changes. So the emphasis is, and it can change right up to 0.5 or 1 millimeter. So if you're really looking, and the endodontist would realize when your working length changes by this much error, then you are not accurate. You can cause pain. You can cause instrument fracture beyond the apex. Remember that the canal straightens. May you use the best night tie. Canal straightens. No canal is straight. It is always curved, and any curvature which once straightens, there is going to be a decrease in the length, and that is what happens when we do our biomechanical preparation. So electronic working length has to be taken twice. Once pre-BMP, once post-BMP. Your master cone should be set at the post-BMP electronic working length and not your pre-BMP electronic working length. Again, this is something which we've really gone into depth and understood. And again, so I would emphasize, do that as I would request you to do this. Caution 2. Again, endomotors, built-in apex locators with endomotors are not accurate. We have literature to tell us that the best apex locators function when you take a static electronic working length, not a dynamic. In endomotors, the files are moving when we are trying to read the electronic working length with those built-in apex locators with endomotors. Please avoid them. Buy your endomotor separately, buy your apex locators separately is my request to you if you're really looking at dependable apex locator working length. Special considerations is what I said. I would come back. These are special cases where apex locators do have an issue. Canal diameters, we would read the red line down. As I said, I've got to go a little faster. In teeth with open apex, that is in 90, 100, the apex locators do not have a good accuracy. If you are really looking at to be at least accurate, you have to use a larger size file. So in open apex cases, you must have in your armamentarium a size 90 ISO and a size 100 ISO. With that, do your working length. You would get some accurate working length, but the European Endodontic Society recommends that apex locators should not be solely be dependent on open apex cases. You must have a combination of an apex locator and a radiographic working length. We've done a study in our department. We emphasize that it should be a combination of 3 working length. It should be done on a electronic working length, on a radiograph, and on a paper point. I can share that article if in case anybody desires. It is the recommended way for us on open apex cases. Primary teeth, again, you do realize that the primary teeth are undergoing resorption. The resorption is more onto the palatal side because the permanent teeth is erupting from that side. So you have irregular walls, but we do not have much literature on primary teeth and electronic working length determination. My experience is also limited, but we have an meta-analysis. So that's the highest level of evidence. For it was in 2013. It's a 7-year-old with very limited studies, but it tells us very clearly that apex locators are also accurate in primary teeth. Sorry, but I do not have much personal experience. The literature for me is very, very scarce as far as this meta-analysis is to be dependent on also. But my pediatric colleagues tell me this, and the article also tells me that if there is no root resorption, you only need to minus 0.5 from your electronic working length. But if you see that if the primary tooth is undergoing an active root resorption, -1. Sometimes I am to the opinion -1 to 2 millimeters if you are seeing active root resorption, because on an IOPA, you would probably not be able to differentiate between the buccal and the palatal wall. And as I said, the resorption occurs at a different rate. So if there is resorption, whatever electronic working length you're getting in a primary tooth, I would advise you 2 millimeters less. Literature tells you 1 millimeter. As far as geriatric patients are concerned, we again have an article, very less articles on geriatrics. So again, for postgraduates, guys, generate your own evidence. I am only telling you direction for research. We do not have much data. How accurate are apex locators in geriatric patients? But as in younger teeth, as I said, Cutler told us 0.5. I recommend that in geriatric patient, whatever apex locator working length you are getting, go down and minus 0.8 to 1, because the apical constriction is supposed to go behind, or because of the cemental deposition in such teeth, is what I understand. This article was something which I found in 2009, which says The error compared to a young towards a geriatric patient, there is no much difference as far as accuracy of apex locators are concerned. One thing I can tell you from my experiences in geriatric patients, sometimes you would never reach the apex mark. You never reach the apex mark is because there is calcification in the apical end. The circuit is not getting completed. Don't try and break that calcification. That's a natural barrier unless and until there is a periapical, then maybe you need to consider it. But if you have a healthy periapical and your apex locator is not showing the apex, just be sure that the apical foramen is calcified. You really need not break that calcification. I hope I get my point clear. Retreatment is something, again, I'll take a couple of minutes to explain about retreatment, accuracy of apex locators in retreatment. In retreatment cases, apex locators tend to show over, in the sense, if your canal is 19 millimeters, it has a tendency to show it to 20 to 21 millimeters. So you are more prone to breakage of instruments beyond the apex in retreatment cases. This is because gutta percha, if left inside the canal, acts as an insulator. It does not allow the electric current to dissipate, and it hampers the accuracy of the apex locators. Simple thing, make sure the gutta percha is out. Make sure that before you take an electronic working length, get the gutta percha out, expose a radiograph, no remnants of gutta percha, put a small file beyond the apex, make sure it is patent, put a drop of saline and do the working length. You would be accurate in retreatment cases also. This presentation would be at the Dental Council site, so maybe you can go back, and it's all schematic and self-explanatory. Sometimes you do have amalgam restorations, or you've got to do root canals through crowns, specifically vital teeth which have been crowned 5 to 10 years back. If it comes in contact with the file, comes in contact with the metal, again, the error is there. Something really simple. I think we missed that slide. You can just put in a sleeve of plastic with the Metapex sleeves, and you are good with as far as the electronic working length is concerned in such teeth also. I said I will recapitulate. I told you that the important small steps are that pre-flare, the ideal access needs to be there, pre-flared ideal access, proper isolation. If rubber dam is not possible, get it with cotton rolls. Always attach the file holder properly, have sufficient size of the shaft of the file to get it. Make sure your file holders are clean. Always have that 5-second rule of adequate moisture. Always remember the concept of apex or zero, minus 0.5 out of it, or 1 millimeter for geriatric patients. Never forget that working length has to be done twice. For your master cone, let the working length be dependent. Which you are going to take is the post biomechanical preparation. I have a small video, a 90-second video, to just recapitulate on what I have told you. So I would now, I think, play that. Okay, this is another slide. It just emphasizes if you do your working length proper, you would get a perfect endodontics case after case. Yeah, you would get it. Make sure even the general dentist, any specialty can get it. Endodontics is simplified. Okay, I have some more things. I forgot. But sometimes, in spite of doing everything right, some things can go wrong. You do realize the World Cup last year, we did everything right, but we still lost. Now that's the troubleshooting. Make sure that few of these things can, the articles tells us that specifically these Wi-Fi modems and mobile phones in the vicinity, in very close vicinity, can also affect the accuracy of the apex locator. So make sure, see guys, I'm only emphasizing you've got to make every negative point out before you can get your apex locator. So these may or may not, but if you have these, the literature tells us that it can affect the accuracy, specifically the Wi-Fi modem, specifically. And that's something which I emphasize because that's something which has been researched on. And this is where I put the cross. Get these things out of your clinic if they are in the vicinity where you're doing the working length. As far as the cardiac monitors are, as the cardiac patients are concerned, no evidence that they have any effect on the functional of apex locator. Vice versa is more dangerous. the cardiac thing not impacting our working length, we will still be able to forgive ourselves. But apex locator having an impact on the defibrillators may just not be very safe. The message I wanted to put here is always take in, the literature is safe, but always consult your cardiologist if he has a patient has a pacemaker with you. I told you that sometimes you would have that the canal length is unstable, it is dancing. So it goes right up to the apex, then comes up. The reasons are self-explanatory on the photographs. Either the lip clip is getting dislodged, so the circuit is breaking, or you have a dirty file holder. So it sometimes comes in contact with the file. The other time you end up missing it. Maybe the reason for a canal length indicator not being stable. Immediately showing apex. So as soon as you put the file, it shows apex. The worst case scenario is an perforation. So again, if you have a perforation, specifically a furcal perforation, this is a very good gadget to know whether you've done a furcal perforation while access opening. Your apex locator would immediately show it as an apex. As I told you, AFAs, they say that it works, but all these things, blood, pus, or these hypochlorite solutions, EDTS overflowing from your cavity can also complete the circuit and show the apex immediately. I told you this canal bar not moving. You put the file, it doesn't move. Excessively dry canal. You will see that. So if you have put a file and you see the canal is not moving, the indicator is not moving, excessively dry canal, follow the 5-second rule. I told you in geriatric patients, in spite of reaching the apex, it is not showing the apex. The reason is that something like this, you see that it's almost calcified down is what I would say. Another reason is a small size in a larger file. In a larger open apex case, again, the same thing would happen, that the canal bar indicator may not move. We've reached the apical limit. That's the end of my seminar. And if you followed this, you would also reach the apical limit in a very, very predictable, and your apex locators will be very, very safe, guys, is something which I needed to emphasize. Invest. My last 2-3 slides. Invest, guys. Everybody is ready to invest in an iPhone 12, a lakh of rupees, which lasts you for 2 years. Another reason which I did not quote because of geopolitical reasons is that people, so the 50 people whom I talked to they said, I asked them which one they use. They said Chinese. Now Chinese apex locators do not. So please, I mean, my colleagues do speak for woodpeckers, but believe me, they do not work. Invest in a good apex locator. It lasts you 5 to 10 years. An iPhone does not. So invest in it, guys. It is something worth it. I can't overemphasize. It's a learning curve. You can't do it overnight. But it's nothing like a magnification. It's not like microscope. It is 60 days. Don't keep it in your cupboard. Most of the people who buy an apex locators is for the showcase. I've seen in dental colleges. When we go for dental council inspection, they come out that time. Sorry, please forgive me, not a political platform, but I feel bad. The more you use it, the faster you're going to get a hang of it. There is a learning curve, but don't blame the apex locator. There is a learning curve. You'll become a pro in 60 days, guys. My sentence, trust yourself. Don't keep it in the cupboard. Trust your apex locator. I trust my apex locator. You ask any of me, I'm famous for not taking a radiograph. Famous. I've taken enough over years. Now I don't take a radiograph. And people do take it after I finish my case. Obviously, 100. 3 cases may have short, long, but that's my gamble. And if you keep doing it, you overcome it. You trust yourself with your apex locators. It becomes like it's your armamentarium. You would not work with anything else. Trust it, guys. That is what my message is. Now, a last message again. It has become a standard of care. So people who are not using it, maybe in the future, we become legally liable for it. Maybe if you have an instrument fracture beyond the apex, you may be cautioned, did you use an electronic working length measurement? If you've not, it's not there. is there in the few of the countries abroad. It is a standard of care. When we say standard of care in legal terms, it makes that it is necessary to use it. And if you are not using it, you're deviating from the standard of care, which may again be an hazard. Finally, I come to the video. Okay, Sir Karunakar, sir, it's exactly 1 hour, 90 seconds more. Yes.
The correct method of electronic working length determination is demonstrated here. Place rubber dam prior to beginning of endodontic treatment. If not possible, at least cotton roll isolation is mandatory. In case of missing tooth structure, pre-endo buildup is recommended. Obtain an initial radiograph and measure the distance between the reference point, like incisal edge or cusp tip, to the anatomical apex. Calculate the temporary working length. Pre-flare the canal and establish patency. To ensure proper apex locator measurements, verify that the canal is not completely dry or overflowing. To obtain adequate moisture, irrigate and suction the excess solution from the pulp chamber. Place a paper point in the canal for 5 seconds. Now we are ready to perform the electronic measurement by turning the apex locator on. Calibrate the apex locator by touching the metal portion of the file holder to the lip clip, demonstrating that the electronic circuit is operating and complete. Place the lip clip into the patient's mouth on the opposite side. Insert a number 10K file into the canal and connect it to the file clip. A double beep audio signal will sound, indicating that working length measurement has commenced. Slowly advance the file further towards the apical region until the apex locator reads over, accompanied by a constant audio tone indicating that the tip of the file is at the apical foramen. Use cotton pliers to push the stopper down to the reference point. The working length of the canal can now be determined by using an endodontic ruler. To establish final working length, subtract 0.5 to 1 mm from the electronic length. Here is your path to easy, predictable and stress-free endodontics.
So that is it. Thank you, sir, for patient hearing and for everybody. I hope I got the message clear, sir. Thank you very much, sir.
Yeah. Thank you very much, Dr. Ajay, for the wonderful presentation. And that reminds me of Anani's quotation saying that if you listen to something, you do forget. If you see something, still you may forget. But if you are involved in something, you will never forget. This lecture reminds me that you have made the presentation so crisp and well articulated. I think all the participants would have got definitely benefited out of this. And coming to the questions, there are many of them have some of the questions and some of the dilemmas in their routine practice. I think few of the questions I have forwarded it to you. You can take up, or one or two I would be asking, which are very routinely expected problems or facing problems in the endodontics.
Sure,
when
sir.
they apex locators.
Please, sir.
Can I read out?
Yes, sir. I would request you to read the questions because I
am coming in. Yeah.
Otherwise,
one question. One question is asked by many of them. That is regarding taken during access opening and obturation, different electronic apex locators, their reliability. What is the reliability of the apex locators?
I am sorry. Could you repeat the question for me, sir? Sorry, I could not.
In the procedures endodontics, what is the reliability? This is a general question asked by many. Reliability of the apex locator, which you already mentioned it.
Yeah.
You can throw a little more light on it.
Yeah. So, sir, that is what I tried. That apex locators, if you choose the right apex locator, it is highly accurate. So that is what my message is. You've got to buy the perfect apex locator. You've got to read the manual about the apex locator, and there is a learning curve with the apex locator. If you master your apex locator, then you are really looking at a very high accuracy. In percentage, it goes up to 97, 98. That means for every 10 cases, you're really looking at 9 cases to be perfect. And with any electronic device, there would maybe some troubleshootings. If you learn to overcome those also, you're really looking at a very good gadget for working length determination, sir.
Yeah, there is another question commonly asked. In case of root resorption, how less the working length should be kept from the apex? Is calcium hydroxide as an intercanal medicament recommended for more than 3 weeks in such cases?
So there are two questions on it. One is the electronic. So I would go. So for when we used to do radiographic working length determination, we were told to minus depending upon whether there was root resorption, whether there was root with bone resorption, the Wien's criteria. Yes. So in apex locators, if there is a root resorption and if we are doing the electronic working length determination, then wherever the apex locator shows it as the apex mark, you have to just minus 0.5 out of that, and that is your working length determination. As far as calcium hydroxide, that is another question. Yes, calcium hydroxide has anti-resorptive properties. So the use of calcium hydroxide as an intracanal medicament to arrest inflammatory apical root resorption is well documented, and hence it is recommended. Yes, please.
Another question which is almost asked by a few of the viewers: how to measure in large accessory canals, especially in apical area or two apical foramen? Please clarify.
Accessory canals, you cannot measure on electronic working length. You cannot negotiate accessory canals. Yes. And so the electronic working length is not possible. Rather, no method of measuring the length of the accessory canal is possible. You can only measure the main canal. And as far as two foramen is concerned, usually they are at the same level. So the working length would be similar for that. That is my understanding. But it is an interesting question. Sometimes the question also foxes us. So maybe I'll also look into this. It's never been asked. So I will definitely look into this. If there are two apical foramens, how do you do the electronic working length? Please, interesting question. Maybe I can take it up. Yes. So whoever has it can have my email, and maybe I can communicate with that person. Interesting, please.
And another question by Mr. Grover: how does dynamic movement of rotary file affect the working length of the apex locator?
Yeah. So the thing is that as I explained it, that for an accurate, I'm not saying they do not work, they work. Yes. But if you're looking at the accuracy between a static working length determination and a dynamic, that is when you are doing the endomotor apex locator, that is the handpiece is moving with the file, compared, the static ones have shown to be more accurate because it reaches, you leave the file in that place and then attach your lip clip and your file holder, so it gives you a much accurate. So the difference in the accuracy between dynamic and static is more. So static is better. That is what my point is.
Another question, probably it is more technical. Does the battery charge affect the accuracy of apex locator reading?
Yes, it does. I showed that in my presentation. You always have to have a fully charged battery. Fully charged. So after the day is finished, you got to charge your battery back before next day morning. And if it is a lithium battery, that is a rechargeable battery, you got to change it after its life is over. But the battery has to be always charged properly. It does affect the accuracy. Yes, please.
Another question is: a device like Control has an option of using apex locators separately with dynamic movement at total rest and not in use. Is this locator fine to use?
That is perfect. You can use it in that mode. So you don't need to buy a separate apex locator in that case. You can use it in the static mode and then again start in the root canal preparation. Yes, no problem.
And also many compliments do follow you. Somebody has sent excellent presentation, sir. Being an endodontist myself, I have got many concepts cleared today with this lecture.
Thank you. Very kind of you, please.
Dr. Ajay.
Thank you, sir.
I think anyway, as Dr. Ajay has given, sharing his mail ID and number, people can also come in touch with him for future correspondence, where he is always open to share his knowledge with everybody.
Yes, please. Thank you.
Hope we are proceeding further on the point. There are many more questions, however, you will be directly connecting them.
Sure.
Coming to the previous webinar, there were many institutions who have participated, and few of them have really outnumbered the presentation, and I must hearty congratulations to all the participants and the toppers, particularly Savita Dental College and Hospital, Chennai, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Yogita Dental College and Hospital, Khade, Jan Nayak Dev Dental College, Sirsa, Thai Mugambiga Dental College and Hospital, Chennai. And the outset, I also have my duty to inform you about the forthcoming webinar organized by the Dental Council of India, that is Techniques of Minor Dentoalveolar Surgeries, that is by my mentor and a great teacher and a wonderful human being, Dr. S.C. Boyer, sir, Professor and Director, CSMSS Dental College and Hospital, Aurangabad. And the moderator is Dr. Jeevan Lata, Madam, Principal Professor and Head of the Oral and Maxillofacial Surgery from Government Dental College and Hospital, Amritsar, Punjab. All of you be there on 14th February 2021, Valentine's Day. Please spare your valuable time for an hour and a half on that particular day. And before I conclude, I will be failing in my duty if I do not thank the Dental Council of India, which has taken tremendous pain to organize this event of webinar, which is a unique program which is done all over the throughout past 20 to 21 webinars are done successfully. And I am sure that this kind of a webinar, particularly during our COVID period, has helped our undergraduate and postgraduate students and the faculty and many of the practitioners to brush up their skills and knowledge. I am sincerely thanking the entire Dental Council of India members and the staff supporting it, the President Dental Council of India, Executive Committee members, and the Secretary Dental Council of India, and the support staff, Mr. Mukesh, and Dr. Virender, who is continuously putting his effort and untiringly supporting all of us to coordinate with this program. I will be also failing in my duty if I do not thank the Almighty, my parents, and all the support staff who are sitting with me to support the event, Dr. Shravan and Mr. Upender. Once again, I want to thank Dental Council for giving me the opportunity and choosing me to moderate this event. That reminds me once again the quotation which is by Swami Vivekananda. What he says is, man who has not made a mistake has not tried anything new in his life. Dear friends who have attended this webinar, all of you make it a point that after all, we have an opportunity to give our best. Let us try the modern concepts, and we have wonderful teachers like Dr. Ajay, who has given and shared the knowledge to all of us. We are thankful to you, Dr. Ajay, for being for this webinar. Once again, I thank everyone, and I also sincerely apologize if there are any pitfalls in the entire program. I definitely take that pitfalls on my side, and all the credit to the Dental Council and Dr. Ajay for putting a wonderful show.
Thank you, sir.
Very much.